You are 10 hours into uh, a pretty grueling 12-hour shift in the emergency
Oh,
department.
yeah, the worst time for a complex case to walk in.
Exactly. The board is full, the waiting room is just totally overflowing, and your pager's going off for, I mean, the third time in 10 minutes.
Typical Tuesday night.
Right. So the triage nurse flags you down and points to bed 4. You walk in, and you see this elderly woman. Let's call her Mrs. Gita. She's in her late 60s.
Okay, setting the scene.
And she looks absolutely miserable. She's clutching her stomach. She's
Mm.
visibly dehydrated. And she tells you she's been vomiting since last night.
Not a great sign.
No. So you do your initial physical exam,
Uh-huh.
and there, sort of hidden away below the crease of her left groin, you feel it.
Ah, the masquerader.
Yep. A tiny, rock-hard lump, barely 2 centimeters across. And it is just exquisite to the touch. The skin over it is, maybe slightly red.
Which is incredibly deceptive.
Totally. To the untrained eye, or even to a really fatigued clinician, it just looks like an angry lymph node, like a minor infection, maybe a benign fatty cyst.
Something you could easily just, prescribe some antibiotics for and discharge her.
Exactly. But if you make that assumption, within a matter of hours, this microscopic little bump will silently initiate a massive cascade of tissue death,
Systemic sepsis.
sepsis, and potentially the death of the patient.
It is the ultimate surgical ambush. I mean, the margin for error here is essentially zero.
Right.
That seemingly innocuous lump is hiding a truly lethal anatomical reality. One that it really preys on cognitive bias and diagnostic fatigue.
Which is exactly why we are stepping into this simulated trauma bay today.
Oh, I love this scenario.
It's brilliant. For those of you joining us in Professor Dr. Selvaraj's Advanced Online Surgery Masterclass, I want you to consider this your immersive clinical gauntlet.
The real deal.
Our mission in this deep dive is to decode what Professor Dr. Selvaraj so profoundly calls the Great Masquerader.
Such a perfect name for it.
We're going to dissect the femoral hernia down to the cellular level, map out the really unforgiving surgical anatomy, and anticipate its most devastating complications before you ever have to actually face them with a scalpel in your hand.
Because this isn't just about passing an exam.
No, not at all. This is about transforming you into the kind of vigilant, problem-solving surgeon who can, stare down these muddy diagnostic waters and see the trap long before it springs.
Yeah, we have to elevate our thinking way beyond simple pattern recognition here.
Right, because a femoral hernia doesn't announce itself with the dramatic presentation of, say, a massive ruptured aortic aneurysm.
Or a massive trauma laparotomy. No, it whispers.
It whispers. I like that.
It completely disguises itself in this very crowded anatomical cul-de-sac. So let's look closer at Mrs. Gita's presentation.
Let's do it.
Because the clues are definitely there, but they require a pretty sophisticated understanding of pathophysiology to actually decipher.
So let's unpack her history and her current physiological state. She tells us this 2-centimeter lump in her left groin has been there for a few weeks.
Crucial detail.
Right. And crucially, it used to be a dynamic mass. It would protrude when she strained. And she has a documented history of chronic constipation, so she's constantly generating these really high Valsalva pressures.
Pushing and straining all the time.
Exactly. And then the lump would spontaneously reduce when she lay flat in bed.
So that tells us right away we have a patent tract.
But today, the rules of the game have entirely changed. The lump is totally irreducible. It is locked in place.
And her systemic symptoms are absolutely screaming that this is no longer just a localized issue in her groin.
The systemic cascade is what should immediately pivot your differential diagnosis far away from a simple lymph node.
Let's analyze the gastroenterological distress for a second. She has severe nausea and worsening vomiting.
But the really critical data point in her history here is that she has been fasting for 12 hours. Yet the vomiting is actually accelerating. I'm going to pause right there because that's a detail a tired resident might just completely gloss over.
They absolutely might.
Why does vomiting on an empty stomach matter so much in this specific context?
Because it indicates a really fundamental disruption of the gastrointestinal plumbing.
Right.
Normally, peristalsis pushes your secretions and any ingested food distally down the tract.
Makes sense.
When you have a mechanical blockage, the proximal bowel initially hyperperistalses to try and overcome that obstruction.
It's fighting against the wall.
Exactly. It's working overtime. But when that fails, the bowel dilates and you get retrograde peristalsis, things move backwards.
Even if she hasn't eaten anything.
Even if she hasn't had a single bite, the stomach, the liver, pancreas, small intestine, They produce liters of endogenous secretions every single day.
Wow. Liters.
Liters. Gastric acid, bile, pancreatic enzymes, they are still just pouring into the system.
And if they hit a barricade down in the groin,
They have nowhere to go but up and out. And this leads to profound dehydration, which we obviously see in her dry mucous membranes.
but it also does something to her chemistry.
It triggers a massive shift in her acid-base balance. She is actively losing hydrochloric acid from the stomach.
Because she's throwing it all up.
Exactly, which can drive her into a hypochloremic, hypokalemic metabolic alkalosis.
So her vascular volume is totally tanking and her electrolytes are just completely deranged.
Yes, and we see the cardiovascular system desperately trying to compensate for that.
Right, her heart rate is sitting at like 120 beats per minute.
That mild tachycardia isn't just from the pain or anxiety.
It's her heart pumping way faster to maintain cardiac output in the face of a rapidly shrinking intravascular blood volume.
Precisely. And then you add the final, really definitive signs of a complete mechanical obstruction. She has not passed stool.
Which could just be her constipation, right?
Sure, but more importantly, she has not passed flatus in 24 hours. Absolute constipation.
No gas at all.
None. You percuss her abdomen, and it is distended and tympanic. It sounds literally like a drum.
Because the loops of bowel proximal to the obstruction are just filling up with swallowed air.
Swallowed air and gas from bacterial fermentation, and then you take your stethoscope, and instead of normal, gentle gurgles, you hear borborygmi.
Borborygmi. Those really high-pitched, almost metallic tinkling sounds.
Yes. That metallic sound is the acoustic result of fluid and air being violently churned through a tightly distended, thin-walled tube.
Driven by an exhausted hyperactive muscularis layer.
Exactly, and when you draw her blood, the physiological stress is just undeniable. Her white blood cell count is 14,700.
A clear leukocytosis. I mean, the normal range tops out around, what, 11,000?
Around there, yeah. So her immune system is aggressively mobilizing.
But it's more than just mobilization, isn't it? It's an acute stress response.
Absolutely. The tissue trapped in that little groin lump is suffering.
It's dying.
The local macrophages and endothelial cells down there are releasing massive amounts of cytokines.
Tumor necrosis factor, interleukins.
All of it dumping into her systemic circulation. This triggers the bone marrow to just push mature and immature neutrophils into the blood, giving you that elevated white count.
Okay, so I am looking at this AI simulated patient. The labs, the vitals, the abdomen, they all paint a picture of a really catastrophic bowel obstruction.
Very clear picture systemically.
But then I look down at her groin and I just see this tiny 2-centimeter bump. It feels cognitively dissonant, you know.
It really does.
I struggle to reconcile the massive systemic failure with such a localized, microscopic physical finding. Why does this specific pathology successfully masquerade as a benign nuisance so frequently?
It really comes down to anatomical real estate and cognitive bias.
The brain playing tricks on us.
Well, the subinguinal region is just incredibly crowded. When a clinician sees a mass below the inguinal crease, especially one that is firm and tender, the brain naturally defaults to the highest probability, lowest acuity diagnosis.
Which is usually an infected lymph node.
Right. Inguinal lymphadenitis is ubiquitous. A patient gets a minor scrape on their foot, maybe a fungal infection between their toes, and those superficial inguinal lymph nodes swell up to trap the pathogen.
It literally happens every single day in the ER.
Every day. Or they think it's a lipoma.
Just a benign accumulation of fat cells.
Exactly. Mesenchymal fat cells arising from the spermatic cord or the round ligament, which just happens to have become slightly inflamed.
The trap is that a strangulated femoral hernia does not present with massive local bruising.
No, it doesn't.
Or a giant grapefruit-sized mass like a massive scrotal inguinal hernia might.
The skein over a femoral hernia might actually look totally normal until the very, very late stages.
And the bowel has already perforated and gangrene sets into the subcutaneous fat.
The masquerade relies entirely on the fact that the external presentation is whisper quiet, while the internal reality is a 4-alarm fire.
Let's pull back the skin then, because if the external presentation is lying to us, we really need to map out the internal reality.
You have to.
We need to explore the exact architecture of the femoral canal, because this isn't just a tunnel, is it? It is an anatomical guillotine.
That is the perfect word for it. The surgical anatomy of the femoral canal is the foundation of everything Professor Dr. Selvaraj teaches in this masterclass.
If you do not have a razor-sharp, three-dimensional mental model of this space, You simply cannot safely diagnose or operate on this patient.
You'll be totally lost. The femoral canal is the medialmost compartment of the femoral sheath.
And the sheath is essentially a funnel-like prolongation of the fascial layers of the abdomen, right?
Exactly. The transversalis fascia anteriorly and the iliac fascia posteriorly. They extend down into the thigh beneath the inguinal ligament.
So it's basically a fascial sleeve wrapped around the major vessels passing from the pelvis down to the leg.
That's it. And the sheath is divided into 3 distinct compartments.
Okay, map them out for us.
The lateral compartment holds the femoral artery.
Right.
The intermediate compartment holds the femoral vein.
Okay.
And the medial compartment, that is the femoral canal.
And normally, what's inside that canal?
Normally, it is virtually empty.
Empty.
Yeah, it just contains a little bit of loose areolar fat, some lymphatic vessels that drain the deep tissues of the leg, and typically one prominent lymph node.
Ah, the lymph node of Cloquet.
Exactly.
Yeah.
But it's essentially a pressure relief valve.
Right. It provides dead space so that massive femoral vein can physically expand when venous return from the leg increases, like during heavy exercise.
That is its intended physiological purpose. But unfortunately, that empty space is also an open invitation for herniation.
The abdominal opening of this canal is called the femoral ring, and the borders of this ring are just notoriously rigid.
It's incredibly rigid.
Let's build the borders. I want to construct this box for our listeners. Anteriorly, what are we hitting?
Anteriorly, forming the roof, you have the inguinal ligament, also known as Poupart's ligament.
Which is the thick, sort of rolled under inferior margin of the external oblique aponeurosis.
Right. It is a really dense band of fibrous connective tissue stretching from the anterior superior iliac spine all the way down to the pubic tubercle.
And it is incredibly strong. It does not yield.
Not even a millimeter.
Okay, so that's our unyielding roof. What about the floor?
Posteriorly, forming the floor of the ring, you have the pectineal ligament, universally known in the surgical world as Cooper's ligament.
This is a structure we're going to talk about a lot when we get to the actual surgical repair later on. It's not just some flimsy band, is it?
Not at all. Cooper's ligament is this incredibly thick, tough, fibrous ridge that is intimately fused with the periosteum of the superior pubic ramus.
So it's basically bone deep.
It is bone deep. When you drive a suture needle through Cooper's ligament, you can literally feel the needle grating against the underlying bone.
Wow.
It is the absolute anchor point of the deep groin.
So our anterior and posterior borders are basically high-tension cables and solid bone.
Yes.
Laterally, we have something we desperately want to avoid cutting.
Laterally, you have the thin fascial septum that separates the canal from the intermediate compartment, the one housing the femoral vein.
And the vein is massive, thin-walled, and highly compressible.
It is actually the only structure in this entire ring that has any give to it whatsoever.
And finally, the medial border. This is really the villain of our story today.
Oh, absolutely.
This is the structure that turns a simple little hernia into a necrotic emergency.
Medially, you have the lacunar ligament, also known as Gimbernaut's ligament. And to truly understand its danger, you have to visualize its shape.
Paint us a picture.
Well, the inguinal ligament attaches to the pubic tubercle, but some of its fibers sort of splay out. They fan backwards and downwards to attach to the pectineal line on the superior pubic ramus.
So it makes a triangle.
Exactly. This triangular expansion of aponeurotic fibers is the lacunar ligament.
And the lateral free edge of that triangle forms the medial border of our femoral ring.
And that free edge is crescent-shaped, it's fibrous, and it is unyieldingly sharp.
Professor Dr. Selvaraj's sources are very, very deliberate in their terminology here. They describe it as razor sharp.
It's no exaggeration. Because of this rigid, narrow, bony, and fibrous box, femoral hernias carry just an astoundingly high rate of strangulation.
The clinical literature in the masterclass tells us that up to 40% of femoral hernias present as strangulated emergencies.
40%. Almost half of the patients walking through the door with this pathology already have dying tissue inside them.
That completely recontextualizes the urgency in the ER.
You have to understand the microscopic progression of that strangulation. Let's say there's a sudden spike in intra-abdominal pressure.
Like Mrs. Gita straining aggressively on the toilet.
Right. That pressure forces a little knuckle of small bowel down through that narrow ring.
Initially, it's just obstructed, right? The bowel lumen is pinched shut.
Yes, but the real danger isn't the bowel obstruction. The real danger is vascular.
Because the blood vessels running through the mesentery of that bowel loop are now being squeezed by the ring.
Exactly.
Yeah.
And physics dictates the exact sequence of how this fails. The venous system operates at a much, much lower pressure than the arterial system.
Okay.
So as the ring squeezes the bowel, the thin-walled, low-pressure veins are compressed and choked off first. Venous outflow completely stops.
But the thick-walled, high-pressure arteries are still actively pumping blood into the trapped segment.
Blood goes in, but it absolutely cannot get out. The tissue becomes rapidly engorged. The hydrostatic pressure inside the capillary beds spikes dramatically.
Which forces fluid out of the vessels and into the interstitial space of the bowel wall itself.
The bowel wall thickens. It becomes heavily edematous. It basically swells up like a balloon filling with water.
And as it swells, it obviously pushes outward against the borders of the femoral ring.
But we just established those borders cannot expand?
Right. The inguinal ligament won't stretch. Cooper's ligament won't stretch.
The only thing that gives way is the biological tissue itself. The swelling bowel forces itself tighter and tighter against that razor-sharp crescent edge of the lecunar ligament.
And eventually, the tissue pressure inside the bowel wall exceeds the arterial perfusion pressure.
The arteries are clamped shut. Ischemia begins.
Game over for the tissue.
Without oxygen, the mucosal lining of the bowel, which is highly metabolically active, begins to slough off and die within hours.
The tissue turns from a healthy pink to a sort of bruised plum color.
And finally to a necrotic, gangrenous black.
And if you don't intervene surgically, that dead black tissue loses its structural integrity entirely and ruptures,
spilling billions of virulent enteric bacteria directly into the sterile peritoneal cavity.
It is a devastating rapid cascade. And the anatomy forces this hernia to take a very specific, almost bizarre trajectory that only makes the strangulation worse.
Yes, the masterclass sources describe it as taking a retort shape.
Right. A retort, for those who maybe haven't spent time in a chemistry lab recently, a retort is this vintage piece of glassware.
Looks very strange.
It has a round bulb at the bottom and a long, narrow neck that bends sharply back upwards, almost folding completely back on itself. Why does a femoral hernia mimic this piece of antique chemistry glassware?
Because it is physically blocked from traveling in a straight line.
How so?
When the hernia sac descends through the femoral canal, it emerges into the subcutaneous tissue of the upper thigh. It pops out through an opening in the deep fascia of the thigh, which is the fascia lata.
This opening is called the fossa ovalis, right, or the saphenous opening, because it's where the great saphenous vein dives deep to join the femoral vein.
That's the one. So the hernia pops out of the saphenous opening. Now, gravity and momentum should theoretically just push it straight down the leg, right, down the thigh towards the knee.
You would certainly think so.
But you'd be wrong. The fascial architecture creates an absolutely impenetrable barricade.
What's blocking it?
Just below the saphenous opening, the deep membranous layer of the superficial abdominal fascia, known as Scarpa's fascia, sweeps down over the groin and firmly, densely fuses with the fascia lata of the thigh.
So it's basically like a waterproof seal across the leg.
It is a definitive, solid anatomical boundary. So the hernia sac exits the saphenous opening, starts to head south, and immediately hits this solid wall of fused fascia.
It literally cannot go down.
The path of least resistance forces it to turn. It is deflected anteriorly, pushing forward, and then it gets pushed superiorly.
It makes a sharp, completely unnatural U-turn, folding back up over the inguinal ligament, pointing back towards the anterior superior iliac spine. It's essentially a highway detour from hell.
That's a great way to put it.
You're driving down a narrow one-way street, which is the femoral canal.
Yeah.
You burst out into an intersection, the saphenous opening. You try to go straight, but you hit a massive concrete barricade, which is the fusion of Scarpa's fascia and the fascia lata.
You can't go straight.
You can't go left or right.
Yeah.
So the massive pressure behind you forces you to violently crank the steering wheel, jump the curb, and double back exactly the way you came, rolling right over the inguinal ligament.
That analogy just perfectly captures the spatial dynamics, and clinically speaking, that severe U-turn is disastrous.
Because it kinks it.
It introduces a secondary point of severe constriction. The bowel isn't just being choked at the narrow femoral ring anymore. The sac itself is now violently kinked at a severe acute angle outside the ring.
A double choke mechanism.
Exactly, which dramatically accelerates the ischemic cascade we just discussed.
Yeah. Let's shift gears slightly and talk about who gets these hernias, because the epidemiological data professor Dr. Selvaraj presents in the AI scenario contains a really fascinating paradox.
It is very counterintuitive.
When we study embryology, we learn about congenital hernias, like indirect inguinal hernias, where the processus vaginalis just fails to close before birth.
Right, you're born with a defect.
But femoral hernias are totally different.
Femoral hernias are almost universally acquired. You are not born with a femoral hernia.
They are a mechanical failure.
They develop over time as a direct result of wear and tear and chronically elevated intra-abdominal pressure.
The major inciting factor highlighted in the masterclass is multiparity, women who have carried multiple pregnancies. Walk us through the biomechanics of that. How does being pregnant 3 or 4 times physically alter the architecture of the groin to invite this specific hernia?
It's a combination of mechanical stretch and hormonal relaxation. During pregnancy, the abdomen expands massively, continuously increasing intra-abdominal pressure for months on end.
Right.
Concurrently, the placenta produces a hormone called relaxin.
Which does exactly what it sounds like it does.
Exactly. It systematically loosens ligaments and fascial tissues throughout the pelvis to prepare the body for childbirth.
It's turning rigid structures into highly elastic ones.
Correct. The transversalis fascia, which forms the anterior wall of the femoral sheath, gets stretched out and significantly thinned.
But more importantly, the masterclass points out that multiparity can physically widen the femoral ring itself.
Repeated pregnancies can completely alter the pelvic floor dynamics. This can create an abnormally narrow insertion of a structure called the iliopubic tract into the pectineal line.
And the iliopubic tract is basically just a thickened band of the transversalis fascia running deep and parallel to the inguinal ligament.
Yes. If its insertion into Cooper's ligament is narrowed or altered by years of pelvic stress, the physical diameter of the femoral ring increases.
What was once a tight, empty little space becomes a wide, gaping funnel.
Exactly.
But here is the paradox I mentioned. The anatomical changes happen early in life. The sources state that the peak incidence for the actual development of a femoral hernia is between the ages of 30 and 40.
Right. Usually right after a woman's childbearing years.
The ring is stretched then. But the life-threatening presentations, the catastrophic strangulations like Mrs. Gita in our ER scenario, almost overwhelmingly occur in women in their 60s, 70s, and 80s.
There's a massive time gap.
If the hole is made at age 35, why does a trap wait 30 years to finally spring?
Because a wide ring initially doesn't trap the bowel, it just accommodates it.
Oh, I see.
At age 35, the canal widens, and perhaps a small plug of peritoneal fat, or the lymph node of Cloquet we mentioned, just gets pushed down gently into the space.
Just hanging out.
Over decades, repeated bouts of coughing, heavy lifting, or chronic constipation slowly, millimeter by millimeter, push the parietal peritoneum down into that space.
It's slowly forming a sac.
Right. For years, it might just be a completely reducible bulge of fat. The patient ignores it.
It's a slow, silent excavation project.
But eventually, a critical mass is reached. The sac is finally large enough, and then a sudden spike in pressure forces a loop of relatively stiff, thick, small bowel down into that tight space.
And crucially, the tissues of an elderly patient are vastly different from a 35-year-old, aren't they?
Entirely different. The fascia is degenerated, the microvasculature of the bowel is already compromised by age or, atherosclerosis.
So it can't handle the squeeze.
When the bowel gets trapped in a 70-year-old, it completely lacks the physiological resilience to withstand the venous congestion. The ischemic cascade happens exponentially faster in elderly tissue.
So the delay isn't the hernia waiting to form. It's the hernia waiting for the perfect storm.
A large sac, a trapped bowel loop, and vulnerable aging tissue.
Which brings us to a massive misconception that we really need to aggressively dismantle for the masterclass students right now.
Let's do it.
I hear this heuristic constantly on the wards. Medical students memorize this little phrase: inguinal hernias are for men. Femoral hernias are for women. It's taught almost as a binary shortcut.
It is an incredibly dangerous oversimplification, and it will absolutely lead you to misdiagnose your patients.
We must look at the actual epidemiological data.
Okay.
Yes, it is true that femoral hernias are overwhelmingly more common in females than in males. The ratio is often quoted as high as 10-to-1 or maybe 4-to-1, depending on the specific study.
Because of the wider female pelvis and the multiparity changes we just discussed?
Correct. However, if you look at a female patient who presents with a groin hernia, statistically, the most common type of hernia she will have is still an inguinal hernia. I want to repeat that so it really sinks in for everyone listening. If a woman walks into your clinic with a hernia, it is most likely an inguinal hernia, not a femoral hernia.
Exactly. Inguinal hernias are the most common hernias in humans, period, male or female. You cannot look at the gender of the patient on the chart and assume the pathology.
The only reliable differentiator is what?
The precise anatomical location of the swelling relative to a very specific bony landmark.
The pubic tubercle, the absolute north star of groin examination.
You must palpate the groin and confidently find that bony prominence on the superior ramus of the pubis. If the origin of the swelling, the neck of the hernia, is located above and medial to the pubic tubercle.
You're dealing with an inguinal hernia.
Exactly. It is exiting the superficial inguinal ring. But if the origin of the swelling is located below and lateral to the pubic tubercle, you are looking at a femoral hernia.
Above and medial equals inguinal. Below and lateral equals femoral.
It is a simple geometric rule, but getting it wrong is catastrophic.
Why is it so dangerous to mix them up?
Because an inguinal hernia, particularly a direct inguinal hernia, has a relatively wide neck and a very low rate of strangulation.
Right.
You might look at an 85-year-old male with multiple cardiac comorbidities and a massive inguinal hernia, and you might conservatively manage him with a truss.
A supportive garment.
Yeah, because the risk of taking him to surgery massively outweighs the very low risk of strangulation.
But if you misdiagnose a femoral hernia as an inguinal one, and you send that patient home with a truss...
You are sending them home with a death sentence.
Wow.
A truss will just aggressively compress the irreducible mass against the sharp lacunar ligament, massively accelerating the necrosis.
It pushes it into the knife.
Exactly. Because of that 40% strangulation risk, the mere diagnosis of a femoral hernia is an absolute indication for operative repair. There is no conservative management here.
Okay, so we understand the stakes. We understand the totally unforgiving anatomy. But let's put ourselves back in the ER with Mrs. Gita.
Back to bed 4.
You're staring at a 2-centimeter lump below and lateral to the pubic tubercle. How do you definitively prove it's a hernia and not one of the many, many other things that can manifest in this exact anatomical space? This is exactly where Professor Dr. Selvaraj's algorithm of diagnosis comes into play.
The algorithm is brilliant because it forces you to be systematic, right? You don't just try to confirm your suspicion. You systematically eliminate all the alternative realities.
The masterclass lists 9 distinct differential diagnoses for a groin swelling. We need to walk through them, not just as a memorized list, but actually understanding the mechanics of why they appear here in the first place.
Let's do it. Let's conquer the differentials. First on the list, obviously, is the inguinal hernia, which we just differentiated using the pubic tubercle. What is number 2?
An undescended testis, or cryptorchidism.
Okay, how does that end up in the groin?
During embryological development, the testes descend from the posterior abdominal wall, travel through the inguinal canal, and drop into the scrotum.
Yeah. Sometimes that descent arrests prematurely, and a testes can lodge right in the superficial inguinal pouch or right at the superficial ring.
Mimicking a groin mass.
Exactly.
How do you rule that out quickly in the ER?
It's usually very straightforward. You palpate the ipsilateral scrotum. If the hemscrotum is empty, that firm mass in the groin is highly likely to be the missing testicle.
Number 3, inguinal lymphadenitis.
We touched on this briefly earlier. The superficial inguinal lymph nodes drain the lower limb, the perineum, the external genitalia, and the lower abdominal wall.
A huge drainage basin.
Huge. Any infection in these vast territories, a cellulitis of the leg, a sexually transmitted infection, will cause these nodes to undergo reactive hyperplasia.
They swell up.
They swell, they become firm, often matted together, and very tender.
Number 4, a lipoma of the spermatic cord or the round ligament.
These are just benign proliferations of mature adipocytes, fat cells, that grow within the connective tissue surrounding the cord structures.
What do they feel like?
They present as a soft, sort of doughy, lobulated mass. They are entirely harmless, but because they occupy the exact same spatial tunnel, they frequently confuse the diagnosis.
Number 5 on the list, an encysted hydrocele of the cord, or in a female patient, a hydrocele of the canal of Nuck.
This is fundamentally a fluid mechanics issue. As the testes descends during fetal life, it pulls a little sleeve of peritoneum with it called the processus vaginalis,
which is supposed to close.
Normally, this sleeve completely obliterates and seals shut. But if a middle segment fails to seal while the top and bottom do close, you are left with an isolated, sealed pocket of fluid trapped in the canal.
It feels like a tense, smooth, cystic structure.
Exactly.
Number 6, the Saphina varix. This one always sounds cool.
This one is hemodynamically fascinating. The great saphenous vein travels all the way up the medial leg and drains into the deep femoral vein at the saphenous opening.
The junction.
Right. The saphenofemoral junction has a crucial one-way ostial valve to prevent the massive column of deep venous blood from rushing backward into the superficial system.
But if that valve fails,
If the valve is incompetent, the high pressure from the deep system just blows backward. The saphenous vein right at the junction dilates massively, forming a saccular aneurysm of the vein.
a giant varicose pouch right in the groin.
It is highly compressible. You push on it, it empties instantly into the femoral vein. You let go, and it rapidly refills from below.
Number 7, a femoral artery aneurysm.
A dilation of the actual arterial wall due to atherosclerosis or maybe trauma. The wall tension increases according to Laplace's law.
This one has to be pulsatile, right?
It is a distinctly pulsatile mass. It expands rhythmically with the cardiac cycle, and this is vital. If you mistake an aneurysm for an abscess or a strangulated hernia and you blindly incise it in the ER without proximal vascular control,
Oh, God.
the patient will literally bleed to death in front of you in seconds.
Number 8, a femoral nerve neuroma.
A very rare benign tumor of the nerve sheath, like a schwannoma or neurofibroma, arising from the femoral nerve as it passes deep to the inguinal ligament.
How do you spot it?
It's firm, and tapping on it might elicit a tenal sign.
Like a shooting electrical pain radiating down the anterior thigh along the nerve distribution.
Exactly.
And finally, number 9 on our differential list, a psoas abscess.
This is a real masterclass in fascial plane tracking. An infection, historically tuberculosis, but nowadays more often staphylococcal, originates high up in the lumbar spine.
Maybe from fasciitis or vertebral osteomyelitis.
Right. The pus collects within the fascial sheath of the psoas major muscle.
And then gravity just takes over.
Exactly. The pus follows the path of least resistance down the psoas muscle, tracking deep behind the retroperitoneum, slipping under the inguinal ligament, and presenting as a fluctuant, tender mass in the groin.
So the pathology is all the way up in the spine, but the physical manifestation is down in the leg.
It's wild.
So we have this massive minefield of 9 distinct, totally different pathologies. How does the clinical algorithm cut through all this noise and accurately isolate the femoral hernia?
The algorithm hinges entirely on a single defining dynamic physical maneuver.
The expansile cough impulse.
Yes.
Walk us through the actual mechanics of the expansile cough impulse. We are placing our hand flat over the swelling and asking the patient to cough. But what are we actually feeling for? Because, everything in the body moves when you cough.
That is the critical distinction. An artery might be pushed forward by surrounding tissues, a lymph node might jump. But a hernia has a direct, patent fluid and gas communication with the pressurized abdominal cavity.
Right.
When the patient coughs, they forcefully contract their diaphragm and their abdominal wall musculature. Intra-abdominal pressure spikes dramatically.
It creates a hydraulic pressure wave.
Precisely. And that pressure wave is transmitted directly down the hollow tube of the hernia sac. When that wave hits the blind end of the sac under your fingers, the lump shouldn't just push forward.
It should inflate.
It should inflate. You should feel it expand laterally, medially, anteriorly. It expands in all directions underneath your fingers. It inflates like a tiny high-pressure balloon.
So if you examine a patient, you confidently identify the mass is definitively below and lateral to the pubic tubercle, and when they cough, you feel that unmistakable multi-directional expansal impulse. You have your diagnosis.
Yes, that combination clinically confirms a patent femoral hernia. You can confidently plan for an elective or urgent repair before strangulation occurs.
But the algorithm also dictates exactly how to proceed if the cough impulse is absent. You move to step 2, which is assessing the specific tactile characteristics.
Because if it's not a hernia, the tactile feedback gives away all the masqueraders.
Right.
If it brilliantly transilluminates when you shine a pen light through it in a dark room, it's a hydrocele. Fluid transmits light, solid tissue does not.
Makes sense.
If you feel a fluid thrill, like a rushing sensation of turbulent blood flow when they cough rather than a solid expansion, that points to the incompetent valve of a Safena varix.
The masterclass sources also point out a very specific subtle visual clue that relates to the local venous anatomy, the distension of the superficial epigastric or circumflex iliac veins.
It's a really brilliant observation of mass effect. Remember how incredibly crowded the subinguinal space is?
Very crowded.
When a femoral hernia sac expands, it physically compresses everything around it. It can impinge on the great saphenous vein or its tiny tributaries, like the superficial epigastric veins that drain the skin of the lower abdomen.
It's literally pinching the outflow tract.
Yes, the arterial blood keeps supplying the skin, but the venous return is blocked by the sheer physical mass of the hernia deep in the groin.
So if you look closely at the patient's lower abdomen,
You might see these superficial veins visibly engorged, dilated, and standing out against the skin. It's a very subtle sign of underlying venous compression caused by a space-occupying lesion in the femoral canal.
this algorithm is incredibly elegant. But I have to throw a massive wrench into the works right now because we need to go back to our trauma bay.
Back to Mrs. Gita.
Let's look at Mrs. Gita. The AI case scenario explicitly states that her 2-centimeter mass is totally irreducible. And crucially, when you ask her to cough, there is absolutely zero cough impulse. The mass is rock hard and immobile. Does that mean the algorithm failed? Do we just cross hernia off the list and start working her up for an incarcerated lymph node?
Absolutely not. And this is exactly where junior surgeons make fatal errors. The algorithm didn't fail. The pathology escalated.
What do you mean?
The absence of an expansile cough impulse in a patient who is simultaneously presenting with systemic signs of a bowel obstruction, the vomiting, the absolute constipation, the high-pitched borborygmi, it does not mean the mass isn't a hernia. It means the hernia has evolved into its most lethal form.
The barricade is completely sealed shut.
Exactly. The lacunar ligament is gripping the neck of the hernia sac so violently, so tightly, that the hydraulic pressure wave generated by the cough simply cannot penetrate past the stricture.
The fluid and gas inside the trapped loop of bowel are completely sequestered from the abdominal cavity.
So the lack of a cough impulse in this specific clinical context is not a reassuring sign that it's a benign lipoma. It is the exact opposite.
It is a terrifying confirmation that the tissue is entirely cut off from the systemic circulation.
It has escalated past merely being obstructed. It is actively strangulated. The bowel is undergoing hemorrhagic infarction as we speak.
So you don't wait for a CT scan.
You do not wait for a CT scan. You do not wait for morning rounds. The absence of that impulse in the face of obstruction is a screaming red alert siren that you need to be wheeling the patient into the operating theater immediately.
Okay, so that scenario is terrifying, but it's loud. Patient looks sick. Their abdomen is distended. They are actively vomiting. The labs are totally deranged. The systemic signs literally scream at you to look for a mechanical cause.
Yes, it's very obvious if you put the pieces together.
But the AI collaborative simulation introduces us to a totally different kind of nightmare. A scenario where the bowel is actively dying in the groin, but the patient might be sitting comfortably on the stretcher just chatting with you with absolutely no classical obstructive symptoms.
The stealth assassin.
We need to talk about Richter's hernia.
Richter's hernia is, without a doubt, the most crucial and deceptive preoperative complication you must master. It subverts every single clinical expectation of what a dying bowel should look like.
Let's define the anatomical geometry of Richter's hernia meticulously. The sources state that it occurs when only the anticenteric wall of the bowel becomes entrapped in the femoral canal, rather than the entire circumference of the bowel lumen.
Let's visualize the architecture of the small bowel for a second. It is a muscular cylindrical tube suspended in the abdominal cavity by a sheet of tissue called the mesentery.
And the mesentery carries the arterial blood supply, the arcades and vasa recta, directly to the bowel.
So the inner curve of the tube where it attaches to the mesentery is the mesenteric border. It is very rich in blood vessels.
Correct. And the outer curve of the tube, the free edge furthest away from the mesentery, is the anticenteric border.
It is a vascular watershed area. It is the furthest point from the primary blood supply, making it inherently much more vulnerable to ischemia.
In a standard classic hernia, the entire tube, the whole circumference, both the mesenteric and antimesenteric borders, folds in half, forms a loop, and gets shoved through the anatomical defect.
Yes, and because the entire tube is kinked and physically squeezed into the hole, the lumen is completely blocked. Traffic stops.
The obstruction cascade begins.
But in Richter's hernia, the femoral ring is so incredibly small and unyielding that it literally cannot accommodate a full folded loop.
So what happens?
Instead, it acts like a pair of microscopic tweezers. It grabs just a tiny knuckle, just a pinch of that highly vulnerable anticenteric wall, and sucks it into the defect.
leaving the rest of the bowel tube completely inside the abdominal cavity.
This is exactly why it is such a deadly trap for the diagnostic physician, because the entire circumference isn't pulled in, the tube is not blocked.
The lumen remains patent.
The bowel is still functionally open, and because it's open, the normal, loud, systemic sequence of bowel obstruction never happens.
The proximal bowel doesn't dilate.
The patient doesn't develop severe nausea or projectile vomiting because gastric secretions can still flow distally right past the pinch.
Their abdomen doesn't become massively distended and tympanic because gas and fluid are passing right by the entrapped piece of tissue.
The patient might literally continue passing normal, formed stool.
But, and this is the silent, deadly reality, that tiny pinched portion of the antimesenteric wall is being mercilessly strangled by the razor edge of the lacunar ligament.
Its already tenuous blood supply is completely severed. That specific patch of tissue is rapidly undergoing ischemic necrosis. It will infarct, turn black, and quietly perforate.
It's like, imagine you are rushing to get into a moving car. You jump in, you sit down, you pull the heavy door shut, but just the fabric sleeve of your jacket gets slammed in the door.
Well, that's a brilliant way to picture it.
Right. The door locks.
Yeah.
The car accelerates down the highway. Traffic is flowing perfectly fine. The engine is running. Everything looks totally normal from the outside. But your sleeve is caught. As the car moves, the fabric is being violently pulled, stressed, and ripped from the seam.
And everything seems to function perfectly until the structural integrity fails and the fabric completely tears away.
That analogy perfectly illustrates the biomechanical failure. The traffic of the bowel flows perfectly, but the localized tissue is being absolutely destroyed. And the consequences of that silent perforation are just catastrophic.
Because there were no loud, agonizing, obstructive symptoms to force the patient to call an ambulance early, they just stay home. They think they just have a pulled groin muscle.
Wow.
Precisely. And by the time they finally collapse at home and are brought into the emergency room 3 days later, the dead patch of bowel has ruptured.
Raw, unsterilized intestinal contents, billions of coliform bacteria, highly corrosive digestive enzymes, and liquid feces are pouring freely through that perforation directly into the sterile peritoneal cavity.
They don't present with a surgical hernia to be fixed. They present in profound, life-threatening septic shock with generalized peritonitis. Their blood pressure is crashing, they are tachycardic, their organs are failing from the cytokine storm.
Which is why the AI collaborative case study provides very specific, non-negotiable advice for the masterclass student. You must operate with an incredibly high index of suspicion.
The clinical rule here is absolute. If you have an elderly female patient who presents with a small, tender, irreducible lump in the femoral region, you must suspect a Richter's hernia.
Even if she has absolutely zero signs of a bowel obstruction.
Even if she's eating a sandwich in the ER, you do not wait for her to start vomiting. You do not ask the nurses to monitor if she passes flatus overnight.
Never. You act aggressively on the localized clinical signs. The exquisite point tenderness and the irreducibility of the mass are sufficient grounds for immediate intervention.
If the presentation is somewhat ambiguous, or maybe the patient is obese and the lump is difficult to palpate definitively, the sources advise utilizing immediate high-resolution cross-sectional imaging.
A CT scan of the abdomen and pelvis with IV contrast.
Exactly. A skilled radiologist looking at a high-quality CT can identify that tiny, isolated knuckle of small bowel with a pinched, thickened antimesenteric wall sitting right at the precipice of the femoral ring, while the rest of the bowel lumen remains contrast-filled and totally patent.
Okay, let's play the scenario forward. We suspect Richter's, we don't wait, we rush her to the operating theater. How does the actual surgical management differ when you find a stealthy Richter's hernia compared to a massive, classic strangulated loop?
The initial exploratory steps are identical. You make your incision, you dissect down through the fascial layers, and you carefully identify and isolate the hernial sac.
Right.
But when you finally open this sac, the visual is profoundly different. In a classic strangulation, you are confronted with a massive, dark, dilated loop of gangrenous small bowel.
But with Richter's, it's subtle.
Very subtle. You might look inside the sac and just find a tiny little nub of tissue, perhaps the size of a grape. It might look severely bruised, plum-colored, or frankly gangrenous and black.
And you have to make a rapid, intraoperative assessment of the viability of that specific patch of tissue.
That is the surgeon's primary burden.
Yeah.
You apply warm, moist saline packs to the bowel. You release the constricting ring by incising the lacunar ligament very carefully, which we will definitely discuss later. and you wait for 5 minutes.
You are watching for three things, right?
Does the normal pink color return? Is there visible, spontaneous peristalsis traversing the segment? And most importantly, when you inspect the mesenteric arcades and vasa recta feeding that segment, can you see or physically feel active arterial pulsation?
If the answer is no to all three, that tissue is non-viable. It is dead. It must come out.
It must be resected. But the resection strategy for Richter's is highly specific because of the localized nature of the necrosis.
Right, if you only have a dime-sized patch of dead tissue right on the antimesenteric border, you don't necessarily have to cut out an entire foot of small bowel, do you?
Not always. If the patch of dead tissue is small and very well circumscribed, you can perform a localized wedge resection.
Explain the geometry of a wedge resection to the masterclass students.
You essentially excise the necrotic tissue by cutting a V shape or a diamond shape directly out of the antimesenteric wall, ensuring you have clean, healthy, actively bleeding margins on all sides.
You are removing the dead zone while leaving the mesenteric border and its vital blood supply completely intact.
But the critical step is the closure. You now have a diamond-shaped hole in the bowel tube. You don't just pull the edges together lengthways, parallel to the tube.
That is a cardinal sin in bowel surgery.
It is. If you close a defect longitudinally, parallel to the long axis of the bowel, you are physically pulling the walls together and artificially decreasing the diameter of the lumen.
Physics, specifically Poiseuille's law, tells us that resistance to flow increases to the fourth power as the radius decreases.
You will create a severe, rigid stricture, essentially causing an iatrogenic bowel obstruction that will require another major surgery to fix months later.
So how do you safely close it?
You must close the defect transversely, perpendicular to the long axis of the bowel. You use specific suturing techniques, typically a 2-layer closure, an inner, full-thickness, continuous layer like a canal suture to achieve hemostasis and invert the mucosa,
Followed by an outer layer.
followed by an outer seromuscular layer of interrupted Lambert sutures to deeply approximate the serosal layers and ensure a totally watertight healing seal. By closing it transversely, you slightly foreshorten the bowel, but you completely maintain the vital, wide caliber of the lumen.
But there is the definitive limit to how large a wedge resection can be, isn't there?
Absolutely. The general surgical rule of thumb is that if the necrotic, non-viable area encompasses more than 50% of the total circumference of the bowel wall, a wedge resection is fundamentally unsafe.
The defect is simply too large.
If you try to close a massive defect transversely, you risk tearing the tissues under immense tension, compromising the microvascular blood supply at the suture line,
Leading to an anastomotic leak.
or creating massive chaotic kinking of the bowel.
In that case, you have to completely abandon the wedge approach.
You must perform a full, formal segmental resection. You clamp and divide the bowel proximally and distally to the necrotic zone. You ligate the corresponding wedge of the mesentery to control the vessels. You remove that entire cylindrical section of the bowel, and then you construct a primary end-to-end anastomosis.
Meticulously sewing the two healthy, well-perfused ends back together.
Exactly.
Okay. So we have resected the dead bowel, we have restored the continuity of the gastrointestinal tract, but we haven't fixed the root cause. We still have a gaping, dangerous hole in the pelvic floor.
We still have to repair the femoral defect itself.
Which brings us to the actual mechanical engineering of the surgery. Whether we are dealing with a massive classic strangulation or a stealthy Richter's hernia, we are now standing over the operating table, and the surgeon must choose their angle of attack. Let's delve into part 5 of Dr. Selvaraj's curriculum, the surgical arsenal and the esoteric variants.
Our sources detail 4 distinct open surgical approaches for repairing the femoral canal, in addition to the modern laparoscopic options.
Let's walk through the open procedures first, because they really illustrate the complex, three-dimensional anatomical puzzle we are trying to solve here.
Let's start with the most direct, historically common route, Lockwood's operation, universally known as the low approach.
Why is it called the low approach? What is the geography of the incision?
It's called the low approach because your surgical incision and your entire field of work are situated completely below the level of the inguinal ligament.
Okay.
You make a transverse incision over the palpable swelling in the upper thigh, just below the groin crease. You dissect sharply through the subcutaneous fat. You sweep away the lymphatic tissue, and boom, you are staring directly at the fundus, the bottom sac of the femoral hernia.
It's essentially like trying to fix a plumbing leak by looking straight up into the drain pipe from below the sink. You have immediate, direct visual access to the visible problem.
It is a beautifully simple, direct approach for uncomplicated elective cases where you are absolutely certain the bowel is healthy. You dissect the sac free from the surrounding areolar tissue. You open it, reduce the benign contents, usually just omentum or a healthy loop of bowel back into the abdomen, and you highly ligate the neck of the sac.
And then you perform the repair from below.
Yes. The classic tissue repair here involves placing heavy, non-absorbable sutures, taking deep bites of the inguinal ligament anteriorly, and firmly suturing it down to the thick periosteum of Cooper's pectineal ligament posteriorly.
You're physically pulling the roof down to the floor, obliterating the femoral ring.
That's the goal.
But there are severe limitations to this approach, right? Think back to our analogy. If you are fixing the plumbing from below the sink, but you suddenly realize the main pipe in the wall has burst, you're in trouble. What happens if you open the sac from below and find gangrenous black bowel?
That is the catastrophic drawback of Lockwood's approach. Working purely from below the ligament gives you incredibly restricted, almost non-existent access to the main peritoneal cavity.
And the femoral ring is rigid and narrow.
If you realize the bowel is dead, you cannot safely pull 12 inches of distended, friable, necrotic small bowel down through that tiny sharp hole to perform a safe segmental resection and anastomosis.
The bowel would just shred against the lacunar ligament.
It would absolutely tear. And if it tears, you will spill highly toxic, bacteria-laden bowel contents directly into the clean subcutaneous wound, guaranteeing a massive surgical site infection.
To safely resect bowel, you need proximal control. You need to access the bowel before it enters the trap. Lockwood's just cannot give you that.
Which is why surgical technique evolved to offer other angles. Let's examine Letheson's operation, the inguinal or transinguinal approach.
Letheson's takes a completely different, slightly counterintuitive path. Instead of making your incision below the inguinal ligament where the lump is, you make your incision above the ligament, exactly as you would if you were repairing a standard inguinal hernia.
So you are entering through the front door to fix a problem in the basement.
Exactly. You incise the external oblique aponeurosis, you open the inguinal canal, you identify the spermatic cord or the round ligament, and you mobilize it and retract it out of the way. This exposes the floor of the inguinal canal, which is formed by the transversalis fascia.
And the femoral ring is located right beneath that floor.
Precisely. You carefully incise the transversalis fascia, and you are now dissecting from above, looking down into the peritoneal space. You locate the neck of the femoral hernia sac exactly as it plunges down into the ring. You grab the sac and you pull it back up, out of the canal and into the inguinal space.
You deal with the contents, ligate the sac, and then you must reconstruct the defect.
How do you actually perform the repair from this superior angle?
From above, the typical repair involves suturing the conjoined tendon, which is the strong, fused aponeurotic insertions of the internal oblique and transversus abdominis muscles down to Cooper's ligament.
It creates a very robust, solid barricade over the femoral ring.
But there's a massive philosophical trade-off here. It sounds like you are dismantling a perfectly healthy anatomical structure.
That is the primary criticism of Letheson's. You are intentionally destroying the integrity of a healthy inguinal canal to gain access to a femoral pathology.
By cutting the transversalis fascia and pulling the conjoined tendon down under immense tension, you are inherently weakening the inguinal floor.
You fix the femoral hernia, but you may theoretically predispose the patient to developing a direct inguinal hernia in that weakened space years later. You are literally trading one problem for another.
Okay, so if Lockwood's is too low and Letheson's destroys the inguinal floor, what is the optimal approach for a high-stakes life-or-death emergency?
The master class strongly emphasizes the third approach, McGeevity's operation, the high approach.
McGeevity's approach is considered by many master surgeons to be the absolute gold standard for dealing with a strangulated femoral hernia.
It provides unparalleled anatomical command. The incision is vertical, made directly over the femoral canal, but it extends significantly high up, well above the level of the inguinal ligament onto the lower abdomen.
So it's essentially taking up the floorboards of the house to see the entire piping system underneath.
It is the ultimate peritoneal approach. You dissect down through the abdominal wall musculature, typically incising the anterior rectus sheath and retracting the rectus abdominis muscle medially. You enter the space of retzius, the retropubic space, completely bypassing the inguinal canal.
You leave the inguinal canal untouched.
Untouched and perfectly intact. You are now working high up in the peritoneal space, Looking down at the entire pelvic floor, you have a magnificent wide-open view of the peritoneum and the bowel before it enters the femoral ring.
This is exactly what you need if you suspect dead bowel.
It gives you total surgical supremacy. If you see gangrenous bowel entering the ring, you don't have to pull it down or drag it up through a tight space. You simply open the peritoneum high up in a clean, uncontaminated field.
You can safely place atraumatic bowel clamps on the healthy proximal and distal bowel loops.
You perform your resection and your precise anastomosis in a wide-open, sterile abdominal cavity. Only after the bowel is repaired and secure do you turn your attention downward to extract the dead sac and repair the defect using a standard Cooper's ligament stitch from above.
It brilliantly separates the clean work from the dirty work.
And the final open approach mentioned is A.K. Henry's approach.
A.K. Henry's is a highly specialized, esoteric approach. It involves a lower midline vertical abdominal incision going straight down the linea alba.
You would almost never use this for a standard unilateral femoral hernia, right?
Right. It is specifically reserved for the rare presentation of bilateral femoral hernias. It allows the surgeon to enter the preperitoneal space centrally and repair both the left and right femoral rings simultaneously through a single incision without violating either inguinal canal.
And of course, we must acknowledge that in 2026, laparoscopic and robotic surgery have profoundly revolutionized hernia repair. Yep. The masterclass details the TAPP and TP procedures.
Laparoscopy provides an incredible magnified view of the posterior anatomy of the groin, the so-called myopectineal orifice of Foucault.
From the inside, looking out, the surgeon can clearly visualize all three potential hernia spaces simultaneously: the deep inguinal ring, the direct inguinal triangle, and the femoral ring.
It's the ultimate diagnostic confirmation.
Yes, and therapeutically, it allows the surgeon to unroll a large piece of prosthetic mesh in the preperitoneal space, effectively covering and reinforcing all three weak areas with a single piece of hardware.
Which brings up the most hotly debated, critical decision point in all of hernia surgery: mesh repair versus primary tissue repair.
This debate is foundational to surgical decision-making. The masterclass guidelines are very definitive. If you are operating electively in a clean, pristine, non-infected surgical field, utilizing a prosthetic mesh is the undisputed standard of care.
You can use a conical mesh plug pushed tightly into the femoral canal or a flat mesh patch placed behind the defect.
Because it adheres to the modern principle of a tension-free repair.
Exactly. When you sew tissues together under high tension, the sutures can easily tear through the fascia over time, leading to recurrence. A mesh acts as a permanent synthetic scaffold.
The body's inflammatory cells infiltrate the pores of the mesh, depositing thick collagen and scar tissue.
It essentially builds a reinforced concrete wall over the defect, dramatically lowering the rate of hernia recurrence compared to pure tissue repairs.
But what if we were back in our nightmare scenario with Mrs. Gita? We are doing a McKeevity's approach. We open the sac, and the bowel is black, necrotic, and perforated. The operative field is literally flooded with foul-smelling, murky, purulent fluid. Billions of enteric bacteria are coating the tissues.
In that specific scenario, the rules of surgery abruptly change. You absolutely, unequivocally cannot use a synthetic mesh.
Why not? Why can't we just wash the area out with liters of saline and antibiotics and put the mesh in anyway to prevent a recurrence?
Because of the microscopic reality of prosthetic materials and bacterial biology, synthetic meshes, like polypropylene, are macroporous. They have tiny holes designed to allow tissue ingrowth.
However, the physical diameter of these pores creates an immunological sanctuary for bacteria. Bacteria are significantly smaller than the human macrophages and neutrophils that are actively trying to hunt them.
So the bacteria can just hide inside the pores where the immune cells are too large to physically squeeze in.
Precisely. The bacteria completely colonize the microscopic crevices of the mesh, and worse, they begin to secrete a sticky polysaccharide matrix called a glycocalyx.
They build a biofilm.
This biofilm is an impenetrable fortress. It blocks human immune cells from attacking the bacteria, and it physically prevents intravenous antibiotics from penetrating the colony.
So the mesh essentially becomes a permanent, indestructible source of chronic infection.
It becomes a smoldering chronic nidus of sepsis. The patient will suffer from relentless fevers, chronic wound drainage, and systemic illness. The biofilm will never resolve.
Wow.
Eventually, the surgeon will be forced to subject the patient to a massive, highly morbid reoperation simply to brutally cut and scrape the infected, scarred-in mesh out of their groin. It is a disaster.
So if you are in a contaminated, strangulated field, what is the alternative? How do you actually fix the hole?
You abandon the mesh entirely and rely strictly on classical primary tissue repair. You meticulously debride all necrotic tissue. You copiously irrigate the field to wash away as much bacterial load as possible. And you use heavy, non-absorbable monofilament sutures like Prolene to perform a robust Cooper's ligament repair.
You forcefully approximate the native inguinal ligament to the pectineal ligament.
Even though we know pulling tissue under tension has a higher risk of the hernia returning down the line.
Yes, a tissue repair in a rigid area absolutely has a higher recurrence rate, but you're choosing the lesser of two severe evils.
A recurrent hernia 5 years from now is a manageable, clean surgical problem. A catastrophic, life-threatening mesh infection today is unacceptable.
You prioritize immediate patient survival and sepsis control over long-term anatomical perfection.
Before we move away from anatomy entirely, the masterclass lecture spends time detailing several incredibly rare, esoteric variants of femoral hernias.
While they're statistically uncommon, I want to dive into them because they brilliantly highlight the chaotic complexity of human biology. We memorize the standard textbook pathways, but these variants show us how biology can just find totally unpredictable routes.
A master surgeon cannot be paralyzed when they encounter an anatomical oddity. You must understand the underlying fascial architecture so well that you can decipher these variants on the fly.
The standard femoral hernia, as we discussed, reliably descends through the femoral ring and down the canal. But sometimes the immense pressure of the abdomen forces the hernia to forge a new path.
Let's start with Lagier's hernia. This one completely defies the standard borders.
Lagier's hernia is an extraordinary biomechanical failure. It doesn't respect the femoral ring at all. Instead of going through the opening, the intense intra-abdominal pressure physically punches a hole straight through the dense interlacing collagen fibers of the lacunar ligament itself.
The hernia sac dissects its way right between the fibers of the ligament. It is incredibly tight, incredibly dangerous, and very difficult to identify surgically because it sits medially to where you expect to find the sac.
Wow. And then there are a whole series of hernias defined by their bizarre relationship to the major vessels of the leg.
Yes, the vascular variants. Remember the compartments of the femoral sheath. Serafini's hernia manages to dissect posterior to the femoral vessels, sliding down completely behind the massive femoral vein.
Thiel's hernia, conversely, passes anterior to the vessels, bulging out right over the pulsating femoral artery.
What about Cloquet's hernia? We mentioned the lymph node of Cloquet earlier.
Cloquet's hernia is a deep tunneling variant. Instead of descending down the canal, the hernia sac protrudes straight down, punching vertically through the pectineal fascia that covers the pectineus muscle.
It essentially burrows under the very floor of the canal, hiding deep in the musculature of the upper thigh.
Hasselbeck's hernia.
Hasselbeck's is highly unusual because of its lateral position. It descends lateral to the femoral artery. It completely bypasses the normal canal structures in the medial compartment, finding a weak point in the lateral aspect of the femoral sheath.
And finally, Nereth's hernia, which is fascinating because it's entirely tied to orthopedic pathology, not just a fascial weakness.
Nereth's hernia perfectly illustrates how skeletal anatomy dictates soft tissue behavior. It is almost exclusively seen in patients suffering from congenital dysplasia of the hip.
Because the hip joint is malformed, the bony architecture of the pelvis is altered. This skeletal distortion physically pulls and shifts the origin of the surrounding musculature and the femoral sheath.
This abnormal tension creates a unique defect that allows the hernia sac to descend deep and hidden behind the femoral artery.
So, as a masterclass student absorbing all of this, I have to take a step back. I'm looking at 4 distinct open approaches. I have laparoscopic TAPP and TEP options. I have the agonizing decision between mesh and tissue repair. And I have half a dozen esoteric, unpredictable variants that might present when I finally open the patient.
It's overwhelming.
How does a surgeon synthesize all this? How do you not just paralyze yourself with overanalysis when you're standing over Mrs. Gita, whose bowel is actively dying?
You survive by anchoring yourself to fundamental surgical principles. You don't try to memorize a flowchart. You synthesize the physiological data in front of you. For a strangulated emergency where the probability of a bowel resection is immensely high, you need proximal control.
Therefore, a higher approach like McGeevity's is the logical principles-based choice.
You avoid prosthetic mesh because the field is contaminated, prioritizing sepsis control. You stick to a robust classic tissue repair.
You strip away the noise and prioritize safety, visibility, and control over anatomical elegance.
That brings tremendous clarity. Control is the ultimate objective. But as Professor Dr. Selvaraj's curriculum terrifyingly points out, even if you make the perfect choices, Even if you choose McEvities, even if you resect the bowel perfectly, even if you decide on a tissue repair, there is a hidden anatomical landmine waiting in the surgical field.
A landmine that can instantly turn a routine, controlled operation into a sudden, chaotic, and frequently fatal exsanguination.
We must transition to the most feared intraoperative complication of this entire procedure. We are moving into the final, critical phase of our discussion.
The corona mortis, the crown of death.
The nomenclature sounds so melodramatic, like a curse from antiquity. But the historical mortality rate associated with this vascular anomaly entirely justifies the name. The coronoma mortis is an aberrant, unpredictable manifestation of the obturator artery.
To understand why it's a death trap, we have to meticulously trace the normal plumbing of the pelvis first. Where is the obturator artery supposed to be?
In textbook anatomy, the obturator artery is a major branch of the internal iliac artery, located deep within the bowl of the true pelvis. Its job is to supply arterial blood to the medial compartment of the thigh, the adductor muscles.
To get there, it travels quietly and safely along the lateral pelvic wall, running along the obturator internus muscle, and it exits the pelvis by diving through a small opening in the obturator membrane called the obturator foramen.
It stays miles away from the superficial groin or the inguinal ligament.
That's the blueprint. But human embryology is chaotic, and angiogenesis, the formation of blood vessels, is highly variable. What happens in the anomaly?
In the anomalous presentation, the obturator artery decides not to branch off the internal iliac system deep in the pelvis. Instead, it arises entirely differently. It branches off the external iliac artery, or more commonly off the inferior epigastric artery, right up high, anteriorly intimately close to the inguinal ligament.
It's starting its journey from the wrong place. And because it's starting from the anterior abdominal wall, but it still has to deliver blood down to the adductor muscles in the thigh via the obturator foramen, it has to take a radically different, highly dangerous path to get there.
Exactly. It has to traverse the pelvis. To get from the inferior epigastric artery down to the obturator foramen, this large, high-pressure artery runs directly horizontally across the superior pubic ramus.
And as it courses over that bone, it hides directly behind the crescent edge of the lacunar ligament.
Which is the exact, precise millimeter of real estate we've been talking about for the last hour.
It is the absolute epicenter of the surgical field. If a surgeon is performing a classic Cooper's ligament tissue repair to close a femoral hernia, they are driving a heavy, curved cutting needle forcefully through the dense inguinal ligament and plunging it deep into the tough periosteum of the pectineal ligament, right on the edge of that bony rim.
And how common is this? Because when we talk about anomalies, people tend to think of 1 in a million medical curiosities. Is this a rare zebra?
It is not a zebra. It is a stampeding herd of horses. The masterclass sources explicitly highlight that the corona mortis anomaly is present in 20 to 30% of all human beings.
In certain studied populations, cadaveric dissections have shown it to be present in up to 40% of cases. You will encounter this anomaly repeatedly throughout your surgical career. It is a statistical certainty.
So I want to play out the catastrophe step by step so the students feel the gravity of it. You are the surgeon. You are deep in the groin. You are focusing on a strong repair. You cannot see the artery because it is completely obscured by the thick fibrous band of the lacunar ligament.
You take a deep, forceful, blind bite with your needle.
You feel the satisfying mechanical crunch as the needle passes through the tough ligament and scrapes the bone. You pull the heavy suture through, and in that fraction of a second, the pristine surgical field is instantly obliterated.
It fills with a welling, torrential, high-pressure fountain of dark red arterial blood. You have lacerated or completely transected the aberrant artery.
But the laceration is only the first part of the disaster. Because it is a muscular artery under high systemic tension, the physical response of the vessel makes it infinitely worse.
The moment the artery is violently cut, the thick, smooth muscle layer within the vessel wall instantly spasms in a desperate physiological attempt to achieve hemostasis. The vessel retracts.
It snaps back like a thick, bloody rubber band. And where does it retract to? It shoots deep downwards, disappearing into the bony, unyielding canal of the obturator foramen.
It's like a bomb disposal technician trying to defuse an explosive. You accidentally snip the wrong high-voltage wire, and that wire instantly violently retracts behind a solid, impenetrable brick wall while it is still sparking, arsing, and causing catastrophic damage.
You know it's there, you know it's lethal, but you cannot physically reach it.
It is the definition of a surgeon's nightmare. You cannot blindly throw a hemostatic clamp into a hole you cannot see. You'll only crush surrounding nerves and shred massive pelvic veins, compounding the hemorrhage.
The bleeding is ferocious. An artery of this caliber pouring blood directly into the open retroperitoneal space can cause a patient to become profoundly hypotensive and enter hypovolemic shock within minutes.
Historically, before the advent of modern anesthesia, rapid fluid infusers and massive transfusion protocols transecting the corona mortis frequently led to rapid exsanguination right on the operating table. The patient would literally bleed to death while the surgeon watched helplessly.
Hence the visceral, terrifying name, the crown of death.
Okay, so if dealing with it once it's cut is a salvage operation, prevention is obviously the only acceptable medical strategy. How do we survive this? How do we definitively prevent it?
The masterclass curriculum outlines a strict multi-tiered protocol. First, if you have the luxury of time, if you are dealing with a reducible, non-strangulated elective hernia repair, preoperative imaging is your greatest weapon. A high-resolution CT angiography of the pelvis with intravenous contrast can vividly map out the entire vascular tree.
The radiologist can definitively tell you before you even make an incision if that anomalous artery is resting on the pubic ramus.
But in our scenario with Mrs. Gita, her bowel is strangulating. We don't have 45 minutes to wait for a CT scanner to open up. We're going straight to the OR.
Exactly. In an emergency, intraoperative anatomical technique is your only shield. The cardinal rule of this operation is absolute. Absolutely no blind bites. You never, ever drive a needle into tissue you have not thoroughly explored and visualized.
How do you safely explore the space behind a tight ligament without accidentally cutting the artery with your scissors during the dissection?
Use blunt tactile feedback. Use your finger. Before you place a single suture anywhere near the lacunar ligament or Cooper's ligament, you must carefully insert an index finger or a blunt right-angle dissecting instrument deeply into the space behind the lacunar ligament.
You gently sweep your finger along the hard, bony edge of the superior pubic ramus. You are feeling, very carefully, the distinct, rhythmic, bounding pulsation of an artery under systemic pressure.
You are feeling in the dark for the bomb wire. If you feel a pulse, you know the anomaly is there.
If you feel it, your entire operative plan pauses. You must painstakingly dissect the loose connective tissue away using blunt dissection until you have direct, undeniable visual identification of the vessel. Once you see it, you definitively diffuse it.
You apply surgical clips proximally and distally, or you pass a suture ligature around it and tie it off tightly. You ligate the aberrant artery before you place a single stitch for your hernia repair.
But let's assume the worst-case scenario. Despite all precautions, anatomy is distorted by inflammation and you hit it. The bleeding erupts. The anesthesiologist shouts over the drape that the blood pressure is crashing. What is the immediate physical crisis management protocol?
The absolute first step for the surgeon. Do not panic. Panic leads to wild, blind clamping. If you blindly thrust a Kelly clamp into a pool of blood in the pelvis, you will catch the iliac vein or the obturator nerve, and you will turn a manageable disaster into an unmitigated catastrophe.
So what is the immediate physical action to stop the hemorrhage?
Immediate, forceful mechanical compression. You take a tightly rolled gauze pack or a sponge stick and you jam it directly, forcefully into the space against the bleeding point on the bone. You apply intense, unyielding, sustained physical pressure to mechanically tamponade the flow of blood.
And while you are holding pressure, your team has to mobilize. You aren't fixing this alone.
Communication is critical. You alert anesthesia instantly. We have major uncontrolled arterial hemorrhage in the pelvis. They need to instantly secure large-bore intravenous access central lines or rapid infusion catheters if possible, and initiate the hospital's massive transfusion protocol.
They need to start pumping O-negative blood, plasma, and platelets into the patient immediately to maintain circulating volume while you control the source.
Okay, you've got physical pressure held. You've got blood and volume coming through the IVs. How do you actually fix the transected vessel?
You slowly, millimeter by millimeter, release your manual pressure and employ high-powered suction to clear the field. You are praying to see the bleeding stump. If, by some miracle, the vessel hasn't retracted fully down the canal and you can visualize the bleeding edge, you rapidly and carefully apply a secure hemostatic clip or a precise suture ligature to tie it off.
But if it has retracted, as it usually does, into that bony canal,
then you are in a salvage situation. You can attempt to pack the obturator canal incredibly tightly with advanced hemostatic biomaterials. Things like Surgicel, which is an oxidized regenerated cellulose, or Floziel, a gelatin thrombin matrix.
These materials rapidly promote a localized clotting cascade. You pack them deep into the canal and apply sustained pressure again, hoping the clot stabilizes the vessel.
What if the pressure and the packing fail? You pull the sponge away and arterial blood is still rapidly welling up.
Then you have to escalate drastically. If the patient's hemodynamics are somewhat stabilized by the massive transfusion, you might call for the interventional radiology team.
They can perform an urgent angiographic embolization. They thread a catheter through the femoral artery in the opposite groin, navigate up into the iliac system, find the bleeding obturator branch, and inject metal coils or a chemical sclerosant to plug the artery from the inside.
And if IR isn't available or the patient is too unstable to move to a fluoro suite, what is the surgical escalation?
Surgically, you must abandon the groin approach. You have to rapidly open the abdomen with a large vertical midline laparotomy. You dive deep into the pelvis using a transabdominal approach, retracting the bladder and bowel.
You have to dissect out the internal iliac artery system and the external iliac system from above, locate the origin of the anomalous bleeding vessel, and ligate it at its source to cut off the inflow.
The masterclass sources mention one final, incredibly extreme measure for this scenario.
Yes, in truly catastrophic, uncontrollable situations where the anatomy is totally obscure, the patient is rapidly exsanguinating, and you simply cannot get proximal control from above, you may have to call for an orthopedic surgeon.
They must urgently bring heavy drills and osteotomes into the general surgery suite and physically drill open the bony superior pubic ramus or aggressively unroof the obturator canal to physically expose the retracted bleeding vessel so you can tie it off.
It is a massive, highly morbid, destructive undertaking, but it is absolutely necessary to stop the patient from bleeding to death on your table.
It's an apocalyptic scenario. And the terrifying thing is that this threat doesn't vanish the exact second the skin is stapled closed.
No, it does not. And this connects directly back to the mandate for intense postoperative vigilance. Let's say you finished the surgery, you did the repair, you didn't see any major arterial spurting, you achieve adequate hemostasis, the wound is closed, and the patient is wheeled to the post-anesthesia care unit, the PACU.
But a slow venous bleed, or perhaps a partially injured artery that was temporarily spasmed shut during the procedure, might start leaking once the patient wakes up, their pain spikes, and their systemic blood pressure normalizes.
Exactly. If the recovery room nurse pages you frantically and says, "Doctor, the patient is tachycardic at 130, their blood pressure is drifting down to 80/50, their hemoglobin level just acutely dropped 2 full grams, and their groin incision is suddenly expanding with a massive, tense, purple swelling."
You do not casually assume they're just a little dehydrated or having normal postoperative pain.
You must instantly, reflexively suspect a delayed corona mortis injury or a major vessel bleed that has formed a massive, rapidly expanding hematoma in the confined space of the groin. You do not wait.
You take them straight back to the operating room, you break scrub, you aggressively reopen the wound, evacuate the massive clot, and find the bleeding source. In vascular complications, hesitation is lethal. Vigilance saves lives.
It is an absolutely intense, unforgiving clinical scenario from the moment they walk through the door to the moment they leave the hospital. Which brings us to our outro. We have covered a massive amount of complex physiological and surgical ground today.
For Professor Dr. Selvaraj's students listening, let's distill the core, absolute, non-negotiable takeaways from everything we've dissected.
The foundational takeaway is profound respect. The femoral hernia is a master of disguise. Never, ever assume a small lump in the groin is a benign process, especially in an older female patient presenting with even vague gastrointestinal complaints.
It requires precise, unyielding anatomical distinction. Above and medial to the pubic tubercle is inguinal. Below and lateral is femoral. That single physical exam finding dictates the entire trajectory of care.
It demands an incredibly high, almost paranoid index of suspicion because of the stealth trap of Richter's hernia. The absence of massive obstructive symptoms or a cough impulse does not guarantee the bowel is safe. Localized point tenderness and irreducibility are sufficient to mandate emergent surgical exploration to prevent silent perforation, massive peritonitis, and septic shock.
And finally, it requires a profound, humbling respect for anatomical variations. The corona mortis is not an urban myth. It is a statistical reality waiting behind the lacunar ligament in up to 30% of your patients. Anticipate it, meticulously feel for it, and deeply respect the legal potential of a blind suture.
Exactly. Know the rigid anatomy, anticipate the deadly complications, and operate definitively before the hernia dictates the terms and declares itself as an unmanageable surgical disaster.
Which leaves us with a final, slightly philosophical thought to end this masterclass session on. As medical students and residents, we spend years memorizing immaculate textbooks. We study the neat, color-coded diagrams of arteries in red and veins in blue. They teach us an idealized, standardized, perfectly predictable version of the human machine.
But the operating room is not a textbook. It does not care about diagrams.
No, it does not. The operating room reveals the chaotic, messy, highly variable reality of human evolution and biology. The next time you are examining a patient in a crowded emergency department and you see a seemingly simple 2 centimeter groin lump, take a breath and pause. Ask yourself, are you looking at the standard safe blueprint, or is biology hiding a crown of death just a few millimeters out of sight behind a rigid wall of fascia? Because true surgical mastery isn't just knowing the established rules of the human body, it is anticipating, respecting, and preparing for the deadly exceptions.